Well, my name is Eric Ruthford. Again, I am a PLU graduate. I was a student here 15 years ago. Back then, Dr. Menzel was our provost, and I interviewed him as a student newspaper reporter, and going and talking to Dr. Menzel was kind of a big, scary deal, and so being up here on the panel with him is quite an honor. So it is very good to be here. The aspect of the subject, or of the value of life that I'm going to talk about relates to the premature birth of our son, Gabriel, who was born at 22 weeks and 6 days of gestation, which is 17 weeks premature. And to give you an idea of what that involved, I'm going to play you a short video that we took when he was 2 days old. Got him off the dopamine now.
That's what Mary was saying.
Yes, and that means his heart is keeping his blood pressure up at the right level by itself.
Okay.
And his blood is a little on the acidic side, so giving him sodium bicarbonate for that.
Already he's getting baking soda, huh?
Yeah. And he's been getting a lot of transfusions lately, just because, well, his body only has about 3 tablespoons of blood in it.
Is that all?
Yeah.
3 tablespoons, wow.
Yeah. Okay. So, that video, the voices are my own and my father's as we're standing and talking about his condition. I should tell you that this story does have a happy ending, so showing people a video of that kind can be pretty upsetting. So I'll get to that part later on. The doctors did not want to get to the point where we were when we had that you saw in that video, with Gabriel having been resuscitated and having been given the breathing tube and all of the various catheters and tubes and wires that were attached to him. On the day that Mary gave birth, at 22 weeks and 6 days of gestation, at about 6 o'clock, her water had broken, so we knew that birth was imminent. We'd been waiting for 9 days, hoping to wait or to extend the pregnancy to the point where we could get to, say, 24 weeks or maybe 25 weeks of gestation, when chances would have been better. But it was clear we were going to have the birth at 22 and 6 days. So at 6:30, we had a visit from a neonatologist, and neonatology is the subspecialty of pediatrics that deals with extremely premature infants. And the doctor came, and what he said was, "I don't recommend that babies should be treated at this stage because the results are so poor. If you give birth after midnight, I'll be the one who comes and does the resuscitation, but my heart won't fully be in it." This statement from the doctor, that he recommended against resuscitation even if we did make it to 23 weeks and 0 days, was somewhat stressful to us. The hospital, Swedish Medical Center in Seattle, happens to be the largest baby hospital in the state, had a policy, and I believe the policy's changed since then, but the policy was that 23 weeks and 0 days was the limit, the lower limit at which the hospital would resuscitate a preemie. The statement of the doctor caused us considerable stress in that we were worried that the doctor might not show up on time, or that we would have the baby early and that there would be no one there to help him. In the end, Gabriel was born at 11:20 p.m. The doctor came and decided to round up, and his official gestational age did remain 22 weeks and 6 days, but he was close enough to being 23 and 0 that they were willing to resuscitate. So then I need to use this thing for the first time. Oh, and it does work. So then this poses, the first question this poses is, one, can he do that? Refuse to provide care when the parents want it? And the answer is yes. doctors are not required to provide care that they believe is futile. What I've included here is an excerpt from the Neonatal Resuscitation Program Clinical Guidelines produced by the American Academy of Pediatrics, which is the governing body that sets standards for pediatricians in the United States. And this is the guidelines on when to resuscitate. So I'll read this. They say you're not supposed to read from PowerPoint slides, but I'm going to do it anyway. When gestation, birth weight, or congenital anomalies are associated with an almost certain early death, and when unacceptably high morbidity is likely among the rare survivors, resuscitation is not indicated. Examples include extreme prematurity, gestational age of less than 23 weeks, or a birth weight of less than 400 grams. And then it lists a couple of other abnormalities that are also included. Now, the bolded words there, resuscitation is not indicated. Not indicated is medical journals speak for it's something that you should not do. Gabriel's weight was 652 grams, which put him in the 97th percentile for size at his birth. They blame that on me, if you can believe that. Let's see, what else to say? Oh, the one other thing to point out about this is these guidelines are for 2010. Keep your eyes in the news. In the middle of the month, I believe October 14th or October 15th, the American Academy of Pediatrics is scheduled to come out with a new set of standards that they haven't said exactly what's going to be in them, but I believe it will include more flexibility on the topic of resuscitation for babies in the 22nd week. I am, of course, very much of the opinion that this should happen. So then the next question is, why would he say that? That the baby should not be resuscitated. And indeed, babies born at that level are in extreme danger. These statistics show a study from Japan in which, in the 22nd week, 63% of preemies born died before they could leave the hospital. And then when you add in the additional outcome of profound neurodevelopmental impairment, you have 73%. Profound neurodevelopmental impairment is the highest level of impairment, and it's talking about someone who is basically almost unresponsive or close to or very limited function. In the 22nd week, 12% could emerge with minimal or no impairment, and there are other levels of lesser impairment in there that I didn't include on the slide just to make it easier to read. As you can see, as you get just another week, chances improve quite a bit more, and then once you get up to the 25th week, it's 14% of the preemies died in that study, and 24% had either died or had profound neurodevelopmental impairment. I've included these Japanese statistics because they're the nice statistics. The American statistics that were quoted to us when we were in the antepartum unit, or the unit where they hold you before you give birth, were even gloomier than that. The American statistics were gloomier. Partially because they were old, and also because in Japan, 22-week preemies have been routinely resuscitated since the 1990s. Over here, it's been a hodgepodge of policies and attitudes by the doctors that determines that. So the survival rates over here vary quite widely. We need to talk about the concept of futility. What does that imply? Futility is, in a medical sense, is defined as care unlikely to benefit the patient. And that's pretty easy to see, that you're providing care that's not going to have any effect. The other is that it's treatment to provide poor quality of benefit. And that is the category we were getting into with our son, that the doctors were concerned about, that even if he did survive, he was so likely to be severely impaired. And with this question also comes into play with the resuscitation of an adult. There has to be a time limit at which the doctors are willing to give up on resuscitating a non-responsive patient. Whatever that time limit may be, given that's appropriate for that age level of patient, you could say, well, if we continue this for 15 minutes, we can stop and then declare the patient dead. Or if you continue further beyond 15 minutes, there is a small percentage of patients who will self-recover and a spontaneous heartbeat will begin. But at that point, the patient's is almost certain to be brain dead because of the deprivation of oxygen to the brain. And so in that case, you would have provided a poor quality of benefit. You're in something of a time crunch when it comes to the delivery of an extremely premature infant. You have to decide before the birth what you're going to do. There isn't really time to examine the child at birth and to say whether, and then to ask the mother, do you want to do this? Do you not want to do it? There's just no time to think about it. The resuscitation that's involved goes far beyond standard CPR. It involves a ventilator tube down the throat. It involves IV catheters, medicines, some of them pretty harsh, put into in these catheters immediately. And it's also adding to this paradox of the time crunch is that the baby was just fine before birth in most cases. There are some cases where the baby has to be born quickly because of a problem in the womb, but in our case and in most cases, that's not what's going on. So the notion of futility here relates to something that has not happened yet to the patient. It's very likely to happen, but it hasn't happened. So you're stuck in a paradox in how do you interpret the future. This is especially compounded by the fact that doctors are not able to predict which children are likely to survive and which are not. A study recently, or a few years ago, was given to neonatologists where they were shown videos of premature births and asked which births or which babies are most likely to survive and which ones are not. And their predictions were about as good as a coin flip. This opens up what you could call a window of death. You could either an opportunity or perhaps a temptation, depending on what you want to call it, in which someone could be allowed to pass away, and you take an action knowing that the result will be the patient's death. It's not quite the same as assisted suicide, but at the same time, your intentions are basically the same. The person will pass away. To us, this seemed similar to the dilemma that occurs when a diagnosis of Down syndrome is given during a pregnancy. 67% of Down syndrome babies are aborted in this country when Down syndrome is detected in the womb, either through ultrasound or amniocentesis. So how is it that you interpret this decision at the birth of a premature child? Are you taking advantage of the disabled at their weakest, or are you reducing the suffering of someone who is likely to die? Let's see. One thing I want to add about the Down syndrome question is that very fact that the Down syndrome babies are often aborted in our culture made us especially suspicious of the doctors when they told us that it was better not to resuscitate him, not to try to have him live. Just the general attitude towards the disabled in this regard, we were afraid that our son could fall prey to that same attitude towards the life of the disabled. We also need to think about autonomy of the patient versus beneficence. Autonomy at the beginning of a pregnancy is a rather easy question in that the mother is autonomous, able to make her own decisions about what she wants in her care. And also the health of the mother is the primary concern. Mid-pregnancy, that model has to change as the child gets to the point at which survival is possible. It changes to balancing maternal-fetal best interests, or beneficence. Who gets to decide on behalf of the child? The doctors, the parents, the state. It becomes a negotiation. And this negotiation is very hard. And to allow me to illustrate this, allow me to place the dilemma of this baby, who is not autonomous, onto an adult who is autonomous. For example, if you have breast cancer patients who have a 30% chance of survival, but the doctor says he won't provide care because it's just not worth trying. A doctor in that case would probably not be allowed to say such a thing. If you were to tell adult patients that they have a fatal condition with a 30% chance of survival, a 5-month treatment, very uncomfortable, and disability is likely, will they say yes to the treatment? Would I say yes to 5 months of treatment with an endotracheal tube down my throat? I honestly don't know the answer to that question. And so, as parents and as doctors of an extremely premature infant, you're placed into, you're having to impose a decision upon this child who has a right to life, but may also, the suffering it also has to be considered. And then there is the question of how early are you talking about things being truly premature? I have argued that hospitals and doctors should be more flexible in the 22nd week than they have been. However, there is eventually a wall that you will hit at which it is hopeless or nearly hopeless for the survival of the child. If I am successful in getting hospitals to be more flexible on the 22nd week, then what about the 21st week, at which point there might be a 3% chance of survival? Is it worth trying at that point? I don't have the answer to that question. And then another question this brings up is medical technologists are trying to build a artificial placenta, or a extracorporeal membrane oxygenation device, which can temporarily do the work of the heart and the lungs. And then you can place this child on this device into artificial amniotic fluid. It would be a very intensive, very difficult procedure for the child, but it could be done and you could save life with it. So then you're going to need some kind of a framework in which to process these new technologies and these new advancements as they come. The belief system of the families involved is also very important. In our case, we believe that life that only lasts a few days is beautiful, glorifies God, even if it includes suffering, and we were willing to take that chance. And we didn't feel like like someone who tries to preserve life but fails has to apologize for that failure or feel that they've done something wrong. The doctor's recommendation that we shouldn't intubate felt at times like an alternative utilitarian religion competing for the dominance of our family. I don't think it's quite fair to say that about the doctors. I don't believe that was their intention. But when there's this sort of, as Christians, there's this sort of separation of church and state that you keep in your life to relate to the secular world, and that separation breaks down when the life of a family member is on the line. I should add here that that was our decision, the way that we processed this decision. However, another family could say, I love my child enough to let him go. I love my child so much that I'm not going to poke him full of holes and inflict very uncomfortable treatment on him for 3 months. I would disagree with that decision. However, it is a mature thinking that may be congruent with another family's belief system. So since we've gotten out of the hospital, we've become something of advocates for babies stuck in this in-between space, writing letters to Swedish's ethics committee and to the ethics committee of the American Academy of Pediatrics. And I've also written an editorial to the journal Pediatrics that I'm going to submit next month. I hope they publish it. And we're asking them to be more flexible about 22-weekers, to use statistics less. They give you categories of death, profound to severe neurodevelopmental impairment, and moderate to severe neurodevelopmental impairment, which when you're in crisis and you're feeling horribly guilty about how things have been falling apart, and you feel like you've done something to cause this premature birth, they sound like death or life without parole. And then I would also encourage the inclusion of a physical or an occupational therapist in the counseling that occurs before a birth. Those people are the ones who deal with these babies after they have left the intensive care unit, and then getting these children caught up so that they can go to school someday, which is something that we have done with Gabriel, and it has gone quite well. So that is the end of what I've prepared to say. I guess the happy ending of the story is that Gabriel did come out of this okay, and he's back there. I don't know if he's going to say anything, but oh, okay. Okay, you want to come sit with me, Gabriel? Okay. All right. No, you don't want to sit with me? Or you want me to sit down? Oh, you want a hug? Okay. Oh, you're going to go see Mommy again. Okay. So, briefly stated, he's got some linguistic delays. He is stuck on purees for eating, has some sensory issues that prevent that. We've had quite a bit of therapy since we left the hospital, and we're hopeful of both physical and feeding therapy. And we're quite hopeful that with enough catch-up, we'll be able to get him into kindergarten, or caught up by kindergarten, or perhaps put him in kindergarten a year late. So that's the end of my talk.